All right, so remember last time we left off on this slide talking about the electrical events associated with the cardiac cycle. And so, just as a quick review, so remember that there are three basic waveforms. So the first one there is the P wave, and then we've got the QRS complex, and then the T wave. And I'll bring my little pointer back so you can see what I'm doing. You don't really need to, but in case you wanted to. So again, the P wave is the first one, and so the P wave is the electrical activity that we associate with depolarization or systole of the atria. And then the QRS complex is what we associate with, or the electrical activity associated with depolarization of the ventricles. And then the T wave is repolarization of the ventricles. So the way these are taken in later classes when you get the opportunity to do this, the most common setup is to have 12 leads. So 12 electrodes placed on somebody's chest wall, and if you look at any one of them, they're not going to look like this, but the collection of all 12 of them is smoothed, and then this is the electrocardiogram you see here is that amalgamation, that collection of all 12 of those inputs. And one of the reasons these are important is if somebody's got an abnormality in this electrical activity, that can give us some ideas about things that might be going wrong with the heart. So, for example, if somebody has an enlarged R wave, so meaning that this peak up here is too tall, one of the things that we might deduce from that is that they have enlarged ventricles. So remember last time we talked about, we talked about the athlete, we talked about Ryan Shea, who is the athlete who died during the 2008 Olympic marathon trials, and that he had a condition called hypertrophic cardiomyopathy, or HCM. And so one of the things that you would observe in HCM is that they have pathologically enlarged ventricles. And so in somebody who had HCM, you would probably be able to observe an enlarged R wave if you did an electrocardiogram on them. Similarly, if there's a depressed ST segment, so if here, as we're getting ready to repolarize the ventricles, if that takes a little bit steeper angle here, then that's something that we would associate with cardiac ischemia. So ischemia is lack of blood flow. So you might see that the last time we talked, there was a slide I showed you. I talked about heart attacks to know and why physical exertion or exercise can bring on a heart attack. And so remember that one of the reasons for that is if there's a blockage in the coronary arteries, then we can't get enough oxygen to the working muscles. And so how you might see that on an electrocardiogram, that might be represented by that depressed ST segment. So if we had somebody do a stress test and they showed abnormal repolarization of the ventricles, or that depressed ST segment, then we might get an idea that perhaps they have some blockage going on that is causing some ischemia to the myocardium. Another fairly common one is a prolonged QT interval. And so basically what you've got there is this RS and then ST segments. Both of those two get stretched out. So this whole thing shifts to the right a little bit. And so that's something that would signify a repolarization abnormality where the ventricles in particular are not repolarizing quite as they should. So there's two other terms on there that are going to be important here in a couple minutes. So systole and diastole we talked about last time. So remember that systole is when the chamber contracts. So atrial systole is when the atria contract. Ventricular systole is when the ventricles contract. And then conversely, diastole is when they are not contracted. Diastole is when those vessels or those chambers are resting. All right. So I mentioned that in part to set up this next slide. So there's a condition, it's also known as a cardiac concussion, but it's called commotio cordis. And so what you get in commotio cordis is fibrillation of the heart. And effectively what happens, so you can see there's a little ECG tracing on the bottom of this slide. Make my mouse go away. So there's a little ECG tracing on the bottom of the slide, so you can see the P wave, QRS complex, and then the T wave. So what ends up happening with commotio cordis is that there's a blow to the chest wall, and this condition is much more common in kids because, since they are not skeletally mature, their bones are not quite as hard as ours are, because everybody in the class is at least very close to skeletal maturity. So in younger kids, let's say 8, 10-year-olds, if they're playing sports like baseball, hockey, lacrosse, those kinds of sports, they're going to have a little bit more compressible chest wall, again because those ribs aren't quite as hard. So or the bones aren't quite as calcified. And so the bones have a little more give to them, they're a little more flexible. So if something strikes them directly in the chest, what that can do then is it pushes that chest wall posteriorly, which can then, it'll compress against the pericardium a little bit, which can then result in physical contact with the heart. Well, if that happens during the T wave, so during repolarization of the ventricles, that can actually throw off the electrical conduction in the heart. And so that's what you see at the very bottom here is that sort of just scattered electrical signal there on the right side of that ECG tracing on the bottom. So that is ventricular fibrillation. It's basically disorganized electrical signals throughout the heart. And so you're not getting that normal atrial contraction, ventricular contraction, rest, and then repeat. You're getting just random signals effectively throughout the heart, and so you're getting just kind of a shaking of the heart. It becomes an ineffective pump. And so the result is that they lose consciousness fairly quickly. I'll show you another ECG tracing here in a second. And I have a video for it. It's pretty easy to find, actually. If you go to YouTube, I decided not to embed it, but if you go to YouTube and look up commotio cordis, there's a video from the 80s from some sort of a karate match. I think it's Taekwondo. But one person gets struck in the chest, and the really interesting thing about that is the guy gets hit in the chest, he looks pretty normal, and then he goes back to the starting position. I'm sure there's a term for that, but basically he goes back to start, get set for the next point, and then suddenly collapses. And so in that case, it's from, obviously a fist to the chest wall. So we tend to see this in sports where there is the possibility of a fairly substantial blow to the chest wall. Like I said, whether that's hockey, lacrosse, baseball, or it can obviously occur in some of your combat sports. So again, that is if the heart is disrupted by mechanical forces, so if the chest wall is pushed in enough that the heart is impinged upon by the pericardium during the T wave, which is a pretty small window, but if that happens, then that's what can bring on commotio cordis. All right, so let's talk about how we regulate heart rate. So we talked in the last lecture about the idea that our resting heart rate is probably somewhere around 70, but that varies, with training status, with age, with gender, those kinds of things. Men tend to have a little bit lower resting heart rate than women do, and lower max heart rates, but they are pretty similar. So you can see a couple things on there. So you got the cardioacceleratory center and the cardioinhibitory center. So remember that there is a cardiac center in the medulla oblongata, which is in your brain stem. And so we talked about this in chapter 12. So where we speed up or slow down the heart is in the brain stem. Remember that left to its own devices, the SA node, the sinoatrial node, which is the pacemaker of the heart, is going to beat 100 times per minute. But under normal circumstances, unless you're somebody like a recipient of a heart transplant, under normal circumstances, the SA node is not operating on its own. It receives constant input from the brain. And so the cardioacceleratory center we associate with the sympathetic branch of the autonomic nervous system. So we associate the cardioacceleratory center with the fight or flight response. So you see this during exercise, but you also see it obviously if you get scared. If one of your roommates jumps out and scares you or something to that effect, you're going to feel your heart beating, your hair stand on end, all that stuff. That's the sympathetic branch of the autonomic nervous system. So when we activate the fight or flight response, we're going to get two effects on heart rate. So the first one there is a chronotropic effect, and what that means is you're going to see an increase in heart rate. So your heart rate is going to speed up. The other one on there is the inotropic effect. And so the inotropic effect is how hard the left ventricle contracts. And so you see two abbreviations on there. ESV stands for end systolic volume. So that is the amount of blood left in the heart at the end of ventricular contraction. So what percentage of the blood have we ejected out? And then the other three letters on there, EDV, stands for end diastolic volume. So when the ventricle is done resting, when it's right about to contract, how much blood is in there? So we talked about with endurance trained athletes that that their stroke volume increases because remember that the left ventricle is more elastic or more extensible. It's actually both. So you can get more blood in there, and so that's one of the drivers of increased stroke volume. Well, that increased extensibility and increased elasticity, what I'm really describing there is an increase in end diastolic volume, meaning that the heart is and again particularly the left ventricle, the heart is able to fill with more blood before it ejects, before it contracts and ejects that blood out. So a related term or a related concept is something called ejection fraction, which is not on this slide, but spelling it's pretty straightforward. And what ejection fraction refers to is what percentage of blood is ejected out with each beat. And so that is essentially the relationship between end diastolic volume, how much blood do we start with before the left ventricle contracts, and then end systolic volume, how much of that blood have we ejected out. So in a normal person at rest, that range is somewhere between 50 and 70% is your ejection fraction. So what that means then is at rest, when the left ventricle contracts, it ejects somewhere between 50 and 70% of the blood out that starts in that chamber. So it ejects out, again, 50 to 70% of that end diastolic volume, the volume that it started with. Normal is about 55%. But that changes under a few conditions. One is during exercise. So when we get that inotropic effect, and before I press too far along, I want to make sure that I point out. So you can see here the sympathetic branch, again, so fight or flight response. You can see the sympathetic branch is green, and so it synapses with the SA node here, also with the AV node, but with the wall of the left ventricle as well. And so that's the fact that the sympathetic branch actually interacts with the myocardium, particularly in the left ventricle, is what allows for that inotropic effect, is what allows for that stronger muscle contraction. As opposed to the inhibitory center that we're going to talk about here in a second, it only synapses with the SA node and the AV node. And the inhibitory center is effectively the brakes on heart rate. It slows heart rate down. All right, so having gotten to that, so with ejection fraction, so back to that during exercise. So during exercise, because of that inotropic effect, because the left ventricle is contracting harder, it's going to eject out a greater percentage of the blood with each beat. So during exercise, for most people, if you're young and healthy, your ejection fraction will jump up from, let's say, an average of 55% to more like 80%. So you're going to eject the vast majority of blood that's in the heart at the beginning of the systolic phase. Then, if you've got a really elite athlete, because remember that their left ventricle is both more elastic, more extensible, but it's also stronger. The left ventricular wall gets thicker, and so they can generate a stronger muscle contraction in the left ventricle. And so, from an exercise standpoint, one of the other things that we see in those elite athletes is that they have a higher ejection fraction. So they can eject out as much as 97% of the blood with each beat. So again, their heart is a more efficient pump because of the training. And then one of the other things we talked about last time was when somebody has a heart attack. So remember that if somebody has a heart attack, if you've got ischemia in the heart, if you've got lack of blood flow in the heart due to some sort of an obstruction, whether that's a blood clot or because of narrowing of the blood vessel with atherosclerosis, that plaque buildup, either way, or a combination of both, you can get ischemia, so you get lack of blood flow to part of the myocardium, that tissue dies, and then that tissue gets replaced with scar tissue. So rather than regrowing or repairing the damaged heart cells, the heart doesn't have the capacity to repair itself. It can't fix itself whenever some of those myocardial cells die. And so as a result, the heart then starts to get infiltrated with scar tissue, so collagen effectively. So that collagen can't contract. And so because of that, now we've lost part of the muscle tissue in the left ventricle wall, for example. And so because of that, the strength of contraction of the left ventricle has gone down because it simply has less muscle mass to be able to contract. It's got some scar tissue infiltration. And so then ejection fraction goes down. So after somebody has a heart attack, if their pre-heart attack ejection fraction at rest was 55%, after a heart attack, it may be something more like 45%. And after multiple heart attacks, it continues to go down. So if somebody has an ejection fraction that at rest is below 40%, then that's considered heart failure. And so you may have some relatives or some people that you know that have heart failure. One of the things that, or a common condition is called congestive heart failure. And so that's typically the result of repeated heart attacks. And again, so because of that infiltration with that scar tissue, the heart is weaker, and so it's not able to eject out as much blood with each beat, and so effectively then that slows down circulation. One of the problems that comes up with congestive heart failure is as the heart becomes a less effective pump, it pushes the blood more slowly through that pulmonary circuit, so through that circuit of blood vessels that runs past the lungs. And so when that happens, more and more of the plasma, the fluid from the blood, starts to leak out into the lungs, and so you start to get fluid accumulation in the lungs. And so as that happens, of course, that's going to impede movement of oxygen into the blood. But as you have fluid accumulation in the lungs, that also makes them a really good site for bacterial accumulation. So that's then predisposes somebody who has congestive heart failure to something like pneumonia. And so that's a pretty common result of congestive heart failure is frequent bouts of pneumonia. So that's ejection fraction, and again related to the relationship between end diastolic volume and end systolic volume. So the cardioacceleratory center then is going to speed up heart rate. It acts through two neurohormones, so it acts through epinephrine and norepinephrine. So these particular neurons, their neurotransmitter is going to be norepinephrine. So here at this site, they're going to release norepinephrine. That's going to cause speeding up. And then you're also systemically going to release both epinephrine and norepinephrine because, again, they're neurohormones. They're going to be released by the adrenal glands atop the kidneys. And so those are going to have systematic effects in any tissue that has receptors for those. So those include blood vessels. So the combination of the two, epinephrine, norepinephrine, both from the direct release of norepinephrine from these neurons as well as the systemic release of epinephrine, has that effect of both speeding up heart rate and then causing the heart to contract more strongly. So that chronotropic effect, speeding it up, inotropic effect, increasing the strength of contraction of the heart. So again, in particular, the left ventricle. Well, what about slowing heart rate down? So the cardioinhibitory center then is the parasympathetic branch of the autonomic nervous system. So remember, the parasympathetic branch, one of the ways to think about that is as the system that we associate with rest and digest. So for most of us right now, unless you're watching this from your treadmill, we are parasympathetic dominant. So we're basically tapping the brakes constantly on our heart rate. So specifically on the SA node and the AV node. So the parasympathetic branch then, its neurotransmitter is acetylcholine, and in the heart, that's actually going to cause a decrease in heart rate, so decreased depolarizations of the SA node and the AV node. So the cardioinhibitory center then is the brakes on heart rate. And so the effect then is during exercise or with the onset of exercise, so remember at rest, you're going to be parasympathetic dominant, so you're hitting the brakes all the time. And then as we start to move from sitting in a chair to moving, so walking, for example, when we do that, then we basically stop hitting the brakes as much. So your heart rate is going to go from 70 up to 80, maybe 90, depends on how fast you're moving. And then once we get more intense, you move from a walk to a jog, or you speed up, then you'll remove that parasympathetic influence. So basically you'll stop hitting the brakes, and then to get above 100, because remember that 100 is kind of our baseline here, that's what the SA node depolarizes at. To get above 100, then now we start hitting the accelerator. So we start hitting the gas, which is the cardioacceleratory center. And so then that's going to have that effect of speeding up heart rate and then increasing contractility. So you're on the brakes all the time until you need to speed up past 100, then you quit hitting the brakes and you start hitting the gas. And so that's effectively what we do with the onset of exercise. If I can advance to the next slide, there we go. So one of the other things related to that is how do we regulate heart rate? How do we know when to speed it up? How do we know when to slow it down? So our particular interest here is actually, my interest is how do we know when to speed it up? And further, during exercise, how does the body know that in order to meet the demands of this particular exercise, I need a heart rate of 130, not 150, but 110 isn't going to get the job done? And basically the way that works is through a combination of feed forward, so anticipating the exercise, or we know that the muscles are going to contract and they're going to require oxygen. So that's the feed forward system. And then there's a feedback system that sort of fine-tunes it. And basically what happens is that the feed forward system anticipates the exercise and really gets the heart rate going at the onset, and then the feedback system sort of fine-tunes it. Like during the exercise, if you speed up or slow down, it's going to cause more minute changes in heart rate once you've initiated the exercise. So here what you've got is a picture of that feed-forward system. So some of those neurons from the primary motor cortex also synapse in the brainstem. So they also synapse in that cardioacceleratory center in the medulla. And so when we're anticipating exercise, then we'll get a speeding up of heart rate before we ever actually move. And so this picture is a graph from a study from the early 2000s, but what they did was they put heart rate monitors on sprinters in the blocks getting ready to run different distances. So you can see that the red line there is an individual who's getting ready to run the 60-yard dash. The yellow line there is somebody running the 220, and then the orange line is somebody running the 440. And so what you've got is this sort of tan square here, or column. That's while they're in the blocks, they're getting ready to start sprinting. And so the person running the 60-yard dash, you'll notice that before the starting gun even goes off, their heart rate is right around 150. So in anticipation of the exercise, because they know that they're about to engage in pretty strenuous exercise, those motor neurons that originate in the primary motor cortex are going to activate that cardioacceleratory center in advance of the exercise. And so what that does is that starts, obviously we start circulating oxygen faster, but we also get the release of epinephrine, norepinephrine, which, remember, are going to free up glucose because we're going to need fuel for that exercise as well. So basically we're warming up without even moving. We're preparing for that exercise. We're mobilizing fuel. We're mobilizing oxygen so that when the exercise does start, we're able to adapt to that more quickly. And so you see there that the heart rate was somewhere around 150 before they even left the blocks, and then their peak heart rate was somewhere around 178-ish. So the vast majority of the adaptation in their heart rate actually happened before the race even started. And the other interesting thing about that is that you see a little bit slower increase, or less of an increase, if somebody is running a longer race. So you can see here for the 220 that their heart rate before they left the blocks was somewhere around 135 as opposed to 150. And so their peak heart rate at the very end of that race ends up actually quite a bit higher. So they're up here more like 190. But because they didn't want to, you don't want to burn fuel unnecessarily. And if you know the exercise is going to last a little bit longer, we see that the heart rates at the start of the exercise are a little bit lower. And so then you get even slightly lower for the 440. And then they're not pictured on here, but they also measured people who ran the 800. So their heart rate was 122 in the blocks. Somebody who ran the 1 mile was 118, and the 2 mile was 108. So somebody running the 2 mile, they're going to run for somewhere 10, 12 minutes, depending on how fast they are. Maybe less than that if we're talking about a really good athlete. So, somewhere between 8 and 10 minutes. But nonetheless, because their heart rate is going to be up for a lot longer than what we're going to see in something like the 60-yard dash, which is only a few seconds, their heart rate was a little bit lower before they started the race. So rather than being 150, it's only 108. And so to use this or to see this on yourself, one of the things that you can do, if you ever wear heart rate monitors before exercise, if you just put it on in the locker room and sit there and see what your heart rate is before you even start moving. And then if you're able to use a treadmill or something, if you stand over the treadmill, like with your feet on either side of the rails, and then speed it up to whatever pace you're going to start running at. We'll pretend you're not going to do a warm-up. You set it to 8 miles an hour, whatever pace that you can run at. You're going to notice that your heart rate is going to speed up quite a bit before you even step on the treadmill. It's kind of neat to watch. So that's that feed-forward system from that primary motor cortex. That gets our engine started before we actually start moving. And then once we've started moving, then we get feedback from the body. So again, the thing we were just talking about, from the higher centers, so from the brain, that's our feed-forward system. Then we get our feedback. And so what the feedback system does is it sort of fine-tunes our heart rate once we've engaged in the exercise. And so the feedback comes from a combination of sources. So you've got chemoreceptors, mechanoreceptors, and baroreceptors, which are a type of mechanoreceptor. So the chemoreceptors, what they do is they monitor things like blood gases. They monitor the oxygenation of the blood. They monitor the concentration of carbon dioxide in the blood. They monitor pH, temperature, etc. And so if the blood gets hotter, if it gets more acidic, if there's more carbon dioxide in the blood, all of those things are stimuli to increase heart rate, because all of those things then indicate that the muscles are working and that we're starting to accumulate the byproducts of energy production. And so because of that, we got to speed up heart rate. So if you're running and you speed up a little bit, or you hit a hill and then you start to accumulate a little bit of lactic acid, or you start to accumulate some of those things that we talked about. So you start to have more acidic blood in that case, then that's going to be a stimulus to speed up your heart rate a little bit more. And then if you slow down and you have a little bit less carbon dioxide in the blood, a little bit less, the blood's a little bit less acidic, those sorts of things, then that is going to remove some of the stimulus for that really higher heart rate, so you'll actually slow it down a little bit. So the chemoreceptor is going to be pretty important. There's some in both the aorta, but also in the carotid bodies. You can see those pictured on the diagram there. The mechanoreceptors, so the feedback that we get from the body, including muscle spindles, joint capsules, etc., those, if we're getting a bunch of feedback from our muscle spindles and our joint capsules, well, then we know that we're moving. And so because we're moving, then we're probably going to need to produce some energy. So that feedback from the muscle spindles and from the receptors in the joint capsules, that's also going to cause an increase in heart rate. And so again, the greater the intensity there, the faster we're moving, that's going to provide a greater stimulus to speed heart rate up. The baroreceptors are effectively the brakes on blood pressure. And so the baroreceptors, what they do is, or we'll talk about where they are first. So there are some baroreceptors in the arch of the aorta, pictured there where the aortic bodies are, but also in the left ventricle and the right atrium. And so if we are getting really high blood pressure, too much volume overload is another way of thinking about that. If blood pressure is getting too high, the baroreceptors act as the brakes, and they cause they decrease that sympathetic influence that's causing an increase in contractility of the heart. So the baroreceptors are the brakes. They slow the heart down. Particularly, they slow down or they decrease how hard the heart is contracting, but they can also have an effect of slowing down heart rate as well. All right, so that's the end of 18. So all the rest of this stuff is chapter 19, and so we're not going to cover 19 in a ton of detail, but we're going to talk about the differences between arteries and veins. So you can see there are three major types of blood vessels. So arteries, again, are going to carry blood away from the heart, and other than the pulmonary arteries, all the rest of them are going to carry oxygenated blood. And then we'll drop down one, and then the veins, so I skip capillaries for now. The veins are going to carry blood toward the heart, and again, other than the pulmonary veins, the rest of them are going to carry deoxygenated blood. And then no gas exchange is going to take place in the arteries or the veins. Where those take place is in the capillaries. So the capillaries are really small microscopic blood vessels. Typically, they're only one cell layer thick. And so that's where oxygen, which is your O2, and carbon dioxide, CO2, that's where gas exchange takes place. So where we drop off oxygen to the muscles and we pick up carbon dioxide, that's going to happen in the capillaries. The other thing on there, the systemic versus pulmonary circulation, I mentioned those last time. So the pulmonary circulation is just moving blood past the lungs for gas exchange to take place, so to drop off carbon dioxide and to pick up oxygen. And then the rest of the circulation is the systemic circulation. All right, so here are the three layers or tunics that we see in blood vessels. So they run from deep to superficial. So the tunica intima is that most internal layer of a blood vessel. And so that includes the endothelium. So remember that the endothelium is the inner lining of a blood vessel. It's that special epithelial tissue where the cells are joined together by tight junctions, and it's nice and slick. It allows the blood to move smoothly through the blood vessels. So the tunica intima includes that, but it also includes a layer superficial to that. So there's a subendothelial layer and then an internal elastic membrane. And so that internal elastic membrane allows that blood vessel to be able to expand and contract. So one of the things that you can notice already is that both arteries and veins have, in their tunica intima, they both have an endothelium and a subendothelial layer, but on the case of the veins, or on the side of the veins, there's not that internal elastic membrane, because the veins, because they're a low pressure system, they don't need all the elastic tissues that the arteries have, because the arteries come from the heart, and so you know that your pulse, you can feel where the artery expands and contracts, and so they have to be able to deal with fairly high pressure, and so to help them deal with that high pressure, they have an additional layer of elastic tissue, and so that's that internal elastic membrane. And then superficial to that, we've got our tunica media, And so the tunica media, the important thing there is that you've got smooth muscle and elastic fibers. And so the tunica media, what it's going to be able to do, it's going to play a really important role in directing blood flow. Because if all of our blood vessels were fully dilated, our entire circulatory system could hold about 20 liters of blood. But of course, we only have about 5. So what we have to do then is direct blood flow to where it's needed at the time, and then direct it away from areas where it's not needed at that particular time. So for example, when you're sitting there resting, and not contracting your calf muscles, for example, only 1 out of every 30 or 40 blood vessels is open. And so instead of directing a bunch of blood flow to the calf, because those cells aren't really using their ATP, they're not running through oxygen very fast, instead of directing a bunch of blood flow there, what we'll do is actually direct it to the abdomen. So that's part of that rest and digest, and we'll direct more blood flow to the liver, to the kidneys, to the small intestine. So we're going to get filtration, we'll get digestion and all that stuff while we're at rest. And in doing that, we will close blood vessels near the skin surface, so we'll direct blood away from the skin, and we'll also direct blood away from the resting skeletal muscles. So in the case of the tunica media, again, so you got that smooth muscle there, and it is responsive to the sympathetic nervous system, so again, to that fight or flight response, and so that's going to cause vasoconstriction. So if you've got vasoconstriction, what happens is that smooth muscle of that tunica media constricts, it contracts. So with vasoconstriction, you've got a closing down of a blood vessel. So what I was just describing to you there, where we're going to direct blood flow away from the resting calf muscle, you're going to get vasoconstriction. You're going to close blood vessels down in that calf muscle, and then you're going to get vasodilation, which is to open up blood vessels in the abdomen. So vasoconstriction, blood vessel closes down, and we reduce blood flow to that area. Vasodilation, blood vessel opens up, and we increase blood flow to that area. And then the last layer there, the tunica externa. Actually, before I move on, there's one more thing on the media. So you can see the external elastic membrane. There's my mouse. So that yellow tissue there kind of looks like Swiss cheese. That external elastic membrane, again, you'll notice that's not on the venous side. So again, because those arteries have to accommodate high pressure coming from the heart, so there's those 2 layers of elastic tissue on really large arteries that we don't see either of those on the venous side. So the last one there is the tunica externa. So you've got this combination of collagen fibers and that's pretty much that. It's collagen fibers, and then you've also got blood vessels, and really big blood vessels like the aorta and then the offshoots off of that. There are, because some of those tissues are so far from the actual circulation, because there's so many layers of tissue between the subendothelial layer, the internal elastic membrane, the smooth muscle, the external elastic membrane, all those layers of tissue don't allow oxygen to diffuse from the bloodstream into those most superficial layers of the blood vessel, into that tunica externa. And so then really big blood vessels have their own circulation. So that's what you're seeing there. The vasa vasorum is the vessels of the vessels, or something to that effect. And so basically what it is circulation for, again, those more superficial tissues. The lumen, the thing at the bottom of the slide, that is the size of the opening. So when we get to the later chapters, when we talk about the small intestine, one of the things we'll talk about a lot is the lumen of the small intestine. That's the inside of it. So on this picture, the lumen of the artery is here, and obviously then the lumen of the vein is here. So you can also see in this picture how the veins collapse pretty easily, because again, they don't have those really thick layers of elastic tissue and really thick layers of smooth muscle around them. So that then obviously affects their shape. All right, so on the arterial side, when blood leaves the left ventricle, it goes into the aorta, and from the aorta goes into the arteries, and then eventually into the arterioles, and from the arterioles, not pictured or not on the slide, but it ends up in the capillaries, and again, that's where gas exchange takes place. So broadly speaking, there's 3 kinds of arteries. There are your elastic arteries, which include the aorta and all the immediate offshoots there. So all the branches directly off of the aorta. So their job is to conduct blood flow from the heart and then get it to the slightly smaller vessels, which are the muscular arteries. So in the case of the muscular arteries, those are most of the named arteries that you might be familiar with. So things like your radial artery, where you take your radial pulse, femoral artery in the groin area, popliteal artery on the back of the knee, those kinds of arteries that you might be familiar with because they're relatively shallow. those would fall under the category of muscular arteries. And so they vary in size quite a bit. Some of them, like the femoral artery, are pretty big, which can be about the size of your pinky, as opposed to some of the others of them that are, in the hand, those, or in the foot even. Those tend to be a little bit smaller, closer to the size of a pencil lead in a mechanical pencil. But what they do is they help distribute blood flow out into those arterioles, and then the arterioles essentially precede the capillary bed. And so you can see there, one of the primary jobs of the arterioles is to provide resistance to blood flow. So while the muscular arteries can play some role in vasoconstriction, vasodilation, it's actually the arterioles that do most of the heavy lifting on that, of directing blood flow away from certain capillary beds. So for example, what you've got here is that you've got, so we're starting on the left side, and so that is obviously an artery that is oxygenated blood. And so we're going to pretend this is the calf muscle when it's working, and so you've got blood flow. In here would be all your little muscle cells would be interwoven through this. And so if the calf muscle is working, all those cells are going to need lots of blood flow, and so all of these things called precapillary sphincters, they're all relaxed. So they're smooth muscle that receives input from the central nervous system. So all of those are going to be relaxed, and so we'll allow blood flow through all these vessels, and we're getting good circulation. Once the muscle cells pick up the oxygen that they need, then we get deoxygenated blood that goes out the right side, so it goes through the capillary bed onto the postcapillary venule, and then eventually dumping into a vein. Thought I had another picture there. Turns out I don't. All right. That's okay. I think that picture comes up in a second. There it is. Yeah, okay. All right. Sorry about that. So let's talk then about capillaries. So in terms of types of capillaries, so there's three types there: continuous, fenestrated, and sinusoidal. I guess before that, I should probably talk about the top part of the slide. So capillaries, the thing I want you to know about those is that that's where gas exchange takes place. So again, that's where we drop off oxygen, that's where we pick up carbon dioxide. And the reason for that is because capillaries, as you can see from this picture, so they have a pretty thin wall. So there is the endothelium here, so there's that one cell layer, and then there is a basement membrane of connective tissue. And then in certain places, you've got pericytes, or I'm sure it's pronounced parasite, but so that you don't think I'm talking about a worm or something, I'm going to really use the I. So pericytes there. And what those are stem cells, so immature cells, and so those are used in repair of the blood vessel. So if there's damage here, the pericytes will help regenerate these endothelial cells, and so that we can continue to have a nice continuous lining to our blood vessel. So it matters, though, that those blood vessels, the capillaries, are particularly thin because gas is going to diffuse based on pressure and concentration gradients. And so oxygen pressure in the blood is going to be higher than oxygen pressure over here in the muscles. And so gas, in that case oxygen, is going to move from the blood into the working muscles because of that pressure difference. But oxygen can only diffuse so far, and the thicker this tissue is, the less likely we make it that oxygen is going to be able to diffuse that far. And so that's why those really large blood vessels have to have their own circulation, have to have that vasa vasorum, is because oxygen simply can't diffuse through that many layers of tissue. So the capillaries are really thin, which is really important because that allows for diffusion of oxygen out of those red blood cells and into the working muscle. So one of the things I've got on my slide here is that the number of capillaries depends upon the tissue. So in the case of skeletal muscle cells, they've got a pretty good capillary network. So they have 2,000 to 3,000 capillaries per square millimeter. So it's pretty good. But it depends upon the type of muscle cell that we're talking about. So your type 1 fibers, your slow twitch fibers, have a lot more capillaries than your type 2X, the fastest of the fast twitch fibers. Because again, those are primarily anaerobic. So your type 1 fibers are aerobic, they use lots of oxygen, and so because of that, they have a lot more capillaries. That said, capillaries are also responsive to training. So if you engage in endurance training, so if you take up running, cycling, etc., one of the things that you're going to see, one of the adaptations in the muscle, is that in those trained muscle cells, so your type 1, your type 2A, and if you do pretty intense intervals, your type 2X fibers, or really long prolonged training sessions, a couple hours or longer, you're going to get more capillaries in the type 2Xs as well. And so effectively then those fibers get better they get better at using oxygen. And so we have to get more oxygen into them, and so we do that by growing additional capillaries around those muscle fibers. So an untrained slow twitch fiber might have 4 capillaries around it, and then after training might have as many as 7 or 8. So they can essentially double their number of capillaries around those individual fibers. We can pretty significantly increase blood flow to trained muscle cells. And some of the other adaptations that you're going to see, again, you're going to have more mitochondria in those cells, because that's where we use those oxygen. And then you also have more of the enzymes inside of the mitochondria that are involved in breakdown of carbohydrates, fat, and protein that involve oxygen somewhat indirectly in that case. So the number of capillaries changes with training. All right, so in terms of the types there, the continuous capillary, that's the one that's pictured there. So that's the type that you're going to see in muscle cells, but as you can tell from the slide, also the skin, the lungs, and the central nervous system. So a few other things on there. So it says that there are pinocytotic vesicles. So remember that pinocytosis is cell drinking. It's one of the ways that we can move things from the blood vessels and into the underlying tissue. And so basically what happens there is you get that little inward bulge. You start to create a vesicle on the cell surface, and then we engulf everything that was in that plasma and then move it across the cell into that underlying connective tissue, into that areolar tissue. So continuous capillaries are the ones we see the most often, at least the more important ones for our purposes, because again, they're going to be in the muscles and the lungs. And then we've got our fenestrated capillaries, so you can see those here. So those kind of look like Swiss cheese. So we see those where absorption and filtration take place. So as you can tell from the slide, see those in the kidney and the small intestine are two of the areas we'll talk about those. And then the last one, the sinusoidal. So they're getting progressively leakier, if you will. So the continuous capillaries, you've got good junctions between those cells. They don't allow much to pass between them. And then as we move to the fenestrated ones, you've got some holes there, so more things are able to move across that endothelial cell. And then finally the sinusoidal ones, they have an incomplete basement membrane. They don't have good tight connections to each other. And so we see those, we've got filtration going on. So in the liver and in the spleen are two of the primary areas that we would talk about. So where you're filtering blood, you'll see those sinusoidal capillaries. All right, so regulation of blood flow. We talked about vasoconstriction, vasodilation. And so what we've got here, so this would be, again, that capillary bed of our calf at rest. So because these muscle cells aren't contracting, they're not producing or not running through much ATP, not having to reproduce ATP, and so because of that, they don't really need very much oxygen. So we can close down all of these precapillary sphincters and limit blood flow to those particular cells. But if we start exercising, then things change a little bit. And so then we move to this schematic, which is what I was showing you a few slides ago. We open up these blood vessels, or these precapillary sphincters, to allow blood flow through the whole capillary bed, getting as much oxygen as we can to those tissues so that we can allow them to make lots of ATP. So again, we're going to control blood flow through vasoconstriction, vasodilation. If you constrict a blood vessel, you close it. Dilate a blood vessel, you open it up. One of the things to know about that is, so again, with the onset of exercise, you're going to get the release of epinephrine, norepinephrine. Both of those neurohormones have receptors in the vascular endothelium, so in that inner lining of the blood vessels, and then in that underlying smooth muscle. And so both of those two are going to cause vasoconstriction. So basically, with the onset of exercise, you close down blood vessels throughout the body. So when you start running or start moving really fast, you're going to release epinephrine, norepinephrine, and you get systemic vasoconstriction. And then what ends up happening is that because of, to some extent, neural control, so part of that feed-forward system, so if I know I'm going to be running, for example, then what we'll do is open up some of these precapillary sphincters in the calf musculature or in the quads or hamstrings, etc. So neural control, part of that feed-forward system, but also you've got some local metabolites that are going to be there. So if we've got this schematic where the brain didn't feed forward, didn't open up those precapillary sphincters, locally, those muscle cells are going to produce more carbon dioxide. They're going to produce more hydrogen. It's going to get more acidic. You're going to see an increase in temperature. And so with all of those things, then those local metabolites act as signals that we need to open up these precapillary sphincters. And so then you open up open up the blood vessels where we need them. So locally, then, we open up blood vessels in response to the byproducts of energy production. So again, increased temperature, decreased pH, so getting more acidic, buildup of carbon dioxide, those kinds of things. The other thing on there is that blood pressure also opens up some of those, or causes a relaxation of smooth muscle. So in those endothelial cells and in the underlying smooth muscle, so particularly in the underlying smooth muscle, you have nitric oxide. So as blood pressure increases, that's obviously going to stretch the arteries, and so that stretching of the arteries causes the release of nitric oxide, which then has the effect of relaxing that underlying smooth muscle, and so then you get vasodilation in response to that. So blood pressure itself, so you're going to see an increase in blood pressure both during endurance exercise and during strength training, so that increase in blood pressure itself will also lead to a relaxation of the smooth muscles, particularly in the muscular arteries and in the arterioles. And so what you've got here is just a graphic of the change in blood flow in terms of where it's directed at rest and during exercise. So you can see at rest, this person has almost 6 liters of blood, so 58 mLs. And so they have all these numbers are milliliters of blood directed toward each of these structures at rest. So one of the things you'll see here is that the brain, as you would expect, gets its blood flow and it stays pretty constant no matter what. So it's getting 750 mLs at rest and then 750 mLs during exercise. So one of the other things that you'll see, though, is skeletal muscles at rest getting 1200 mLs. Well, during exercise, you're going to need a lot more blood flow to the working muscles, so they're going to get 12,500 mLs. The other thing that you'll notice down here at the bottom, so our cardiac output increased quite a bit, so more than 3 times. So we have 17.5 liters a minute. So again, this person says strenuous exercise. They could probably go harder if they were your normal college age individual, but they're working pretty hard. So big increase in blood flow to the muscles, big increase in blood flow to the skin, somewhat of an increase to the heart. But one of the things you'll see is that the kidneys, blood flow to the kidneys goes down, blood flow to the abdomen goes down, and everything else stays about the same but drops just a little bit. So again, what we do with this, the balance between the sympathetic and parasympathetic branches of the autonomic nervous system is with rest and digest. So with the parasympathetic dominance, we're going to direct blood flow away from the skeletal muscles, away from the skin, toward the kidneys and toward the abdominal organs like the liver, small intestine, etc. And then with sympathetic stimulation, so fight or flight stimulation, we're going to then direct blood flow away from the kidneys, away from the liver and small intestine, and toward the skin and toward the skeletal muscles. All right, so on the venous side of things, so what we've got there is less elastic tissue, appreciably none, so less elastic tissue, and then a thinner layer of smooth muscle. So you can see here on the arterial side, so there's a pretty thick tunica media on the artery, and then relatively thin here on the vein. And then some other differences, as you can see there, so there's a larger lumen, larger opening on the venous side, less muscle in the tunica media, and then the tunica externa is pretty thick and has lots of collagen. So if anything, the tunica externa on the venous side is a little bit thicker. See if I can get this to, there we go. All right, so venous return. Remember that venous return is blood flow coming back to the heart. So the way that venous return works, there are 3 things that contribute, or three ways that we affect blood flow back to the heart. So the first one on there is the muscular pump. And the muscular pump is what's being depicted there. So as the muscles contract, then that's going to compress this vein, which then pushes blood superiorly back toward the heart. And then when those muscles relax, that would tend to pull this blood back down, but this vein here, or sorry, not this vein, this valve is pretty similar to what we see in the heart. So they're most similar to the semilunar valves. And so that valve is going to prevent backflow back down here. So effectively, every time these muscles contract, they're going to push some blood up past that valve. Then when they relax, it's going to suck it back, but that blood will be stuck up here because of this valve. And then there'll be some more muscle up here. When they contract, push blood up, and then you repeat that process until that blood gets back to the heart. So that's the muscular pump. But obviously, we're not contracting the muscles of our lower body all the time, so the muscular pump isn't always returning blood back to the body. So another thing that helps direct blood flow back to the heart is the respiratory pump. And so what we get there is, as you're breathing, as you're getting changes in pressure inside of the thoracic cavity, that serves a similar function. So you get compression and relaxation, and then that helps kind of pull blood flow back toward the heart. And then the last thing on there, sympathetic venoconstriction. So again, we're dealing with the sympathetic branch of the autonomic nervous system there, and so that systemic constriction of the blood vessels helps also push blood back toward the heart. So another thing on there is that veins serve a capacitance role. So you can see from the little pie chart that particularly at rest, about 2/3 of our blood is on the venous side, and then the remainder obviously is on the arterial side. And you can also see how much blood flow goes past the lungs. So 12% is in the pulmonary blood vessels, so quite a bit. And then again, so the important thing there is that particularly at rest, most of the blood is on the venous side. So that's where that larger lumen comes into play, is they store blood effectively at rest. Now that said, remember that we're turning over the blood once per minute, so you're turning over all 5 liters every minute, but most of that kind of stays on the venous side. So because you don't need to deliver a ton of oxygen at rest because your tissues aren't that active. So then a lot of the blood's on the venous side. All right, so varicose veins, just as an aside, so varicose veins are what happens when one of those valves that I mentioned becomes defective. And so you start to get pooling of blood in that vein. Typically occurs in surface veins, as you can tell from the picture, oftentimes below or right behind the knee. Usually it's in the lower body because of gravity. If you have a job where you have to stand all day, so you work on an assembly line, you're a hairdresser or something to that effect, that gravitational pull tends to be a little bit more pronounced, and so that is those people that stand all day for their job tend to have more problems with varicose veins. And the reason they occur in surface veins is there's simply less lying atop them. There are less structures superficial to them to help reinforce that vein. So you have essentially just some layers of fascia and skin atop those surface veins, and so there's not a whole lot sort of reinforcing that vein. As opposed to a deeper one, there's muscles sitting on top of it or sitting around it, and so that helps sort of reinforce that tunica externa. And then venous pooling. So again, the veins serve a capacitance role. So most of your blood is again on the venous side. And so one of the things that we'll see is if somebody is engaged in fairly intense exercise and then they suddenly stop. So if you're like sprinting full speed and you suddenly stop, it can be pretty uncomfortable. It can cause some lightheadedness because one of the things that's going to do is it's going to remove that muscular pump. You're going to get a really sudden reduction in venous return. And if less blood flow is coming back to the heart, then less blood flow is going to the brain. And so then that can cause dizziness temporarily. So that's one of the reasons that you're supposed to engage in a cool down is to basically kind of to reduce the suddenness and drop off of that venous return back to the heart. And you also see that muscular pump is really important if you have to stand for prolonged periods of time. So you see this sometimes in like military parades or at weddings, another place. So one of the things you're often instructed not to do is to stand there with your knees locked. It's pretty comfortable to stand there with your knees locked, and the reason it's more comfortable is if you stand there with your knees kind of hyperextended, what's holding you up is effectively the posterior capsule of the knee joint, and so that doesn't take any energy. That's just collagen, as opposed to if you stand there with your knees slightly flexed, well, what's holding you up then is the muscle contraction of the quads in particular. And so if you're standing there with your knees slightly locked, you're getting slightly unlocked, slightly flexed, you're getting some level of muscle contraction. And the good thing about that low level muscle contraction is that's helping to push some blood flow back toward the heart. Whereas if you stand there with your knees locked, you're removing that muscular pump. And so the only thing really that is having any effect on driving your venous return is that respiratory pump. And so if you're standing for a really long period of time, sometimes that respiratory pump is insufficient, and so then people get dizzy and faint. So sometimes you see people faint at weddings, and that's part of it is because of the lack of a muscular pump when they're standing for that long of a period of time. All right, so let's talk about hypertension. So hypertension is high blood pressure. Most of us tend to our blood pressure tends to increase as we age. And so one of the big drivers of that is that the arterial system tends to become increasingly inelastic as we age. So part of that is atherosclerosis. So you get those buildup of plaques associated with levels of or high levels of LDL or bad cholesterol, also associated with high intake of saturated fats. And so as those plaques accumulate on the arterial walls, then that obviously makes the arteries less elastic. And so the effect then is to increase diastolic pressure, to increase resistance to flow. And remember that as diastolic pressure goes up, systolic pressure has to go even higher to try to overcome that resistance to flow. And so if somebody has blood pressure 140/90 or higher, and actually that number dropped recently. I think the newest diagnostics were like 130/90. And remember that normal is 120/80. So the effect then is that the heart is basically exercising, if you will, all the time. So it's working harder than it has to all the time. And so then the result is that you get a pathological enlargement of particularly the left ventricle. So the left ventricle gets stronger, gets thicker, but it doesn't get more extensible. So it's similar to but different from HCM. So it is a pathological enlargement of the heart, but you don't see all that scar tissue like you see with HCM. But it's similar in that you get an accumulation of muscle, in particular in the left ventricle of the heart. You get an enlargement, and basically the heart gets larger, but it becomes a less effective pump. It gets the muscle gets kind of flabby. And so that's then one of the things that can lead to eventually to heart failure. So one of the other things about hypertension, about high blood pressure, is that it can sneak up on you. Because what are the symptoms? Nothing really, until it gets really, really high. And then sometimes people complain about headaches or complain of headaches. But if you have just low-level hypertension, 140/90, you probably don't know. So if you don't get your blood pressure checked, at least once annually at your physical, then you wouldn't know that you have hypertension. And so one of the things that becomes problematic is people will have high blood pressure for 5 or more years before they ever notice, before it ever gets diagnosed. And so that can cause some pretty significant damage to the heart, but also then to other organs like the kidneys. The kidneys are particularly sensitive to high blood pressure. So in terms of blood pressure response to exercise, so we talked about strength training, that both diastolic and systolic pressure go up, and it can go up pretty significantly. In endurance training, diastolic pressure stays about the same, so usually stays about 80. It might jump up to more like 100, but in some cases, diastolic pressure during endurance exercise, so like walking during running or cycling, those kinds of things, the diastolic pressure can actually go down a little bit because of the widespread vasodilation in the working musculature. And so diastolic can go down, systolic goes up, but it only goes up, depends on how hard you're running, but 200/100 would be a pretty common level of blood pressure in an endurance athlete. You get a bigger increase in blood pressure during so VUE, upper extremity. So during upper body exercise, if you do like an upper body bike, you're going to get a bigger increase in blood pressure because the blood vessels of the upper body are smaller than the ones of the lower body, so it's easier to compress them. So diastolic pressure goes up a little bit more during upper body exercise. So again, like doing an upper body bike, you're going to see a bigger increase in diastolic pressure, which then, to account for that, you get a bigger increase in systolic pressure. And then the last thing on there is recovery. So after exercise, particularly after endurance exercise, you're going to get a drop in blood pressure. And the reason for that is if you're familiar with the idea of a muscle pump, right? Everybody's probably done some exercise where you've lifted weights, or you've run, or you've upper body cycled or something, and you notice that the muscles are a little bit swollen after that exercise. May not be much, but they're swollen a little bit. And so what's happened there is you've driven some of the plasma volume from the blood into the muscles. And so that they're swollen because they have a little bit more fluid in them than they would otherwise. Well, as you move more fluid from the central circulation into the muscles, the effect then is less blood in the central circulation, less cardiac output. Basically, you get a reduction in blood pressure when you lose blood volume. And effectively, you lose blood volume a little bit whenever you move that plasma volume into the working muscle. So after exercise, you see a little bit of a drop in blood pressure during recovery, which is one of the reasons that mild and moderate intensity exercise is recommended for people who are hypertensive. One is to help with weight control, but the other reason is to get that temporary recovery effect where you get a drop in blood pressure. And then the last thing is shock, but I'm not going to ask you any questions about shock, so we'll skip over that for now. So that is all of chapter 18 and 19, so we're done with all that. So we'll move on to the lungs next time, so we'll see you then.